and welcome to the Cottage Center for Orthopedics Meet the Doctor featuring Dr. Jervis Yao. I'm Christy Borneman, the Marketing Manager for Cottage Health, and it's my privilege to moderate this evening's presentation. Before we get started, I'm just going to go through a few housekeeping slides to optimize your experience during this webinar. If at any point during this presentation you have technical issues, feel free to send a private chat to Zoom help and someone will be able to assist you. At the conclusion of this presentation, we will host a question and answer session. Please use that Q&A button at the bottom of your screen to ask questions at any time during this presentation. This presentation is being recorded, so you will receive an email within the next week or so with a link to view the presentation as well as the PowerPoint slides. And now it's my privilege to introduce Dr. Jervis Yao. He's a board-certified orthopedic surgeon who specializes in sports medicine and joint preservation surgeries of the shoulder, hip, and knee. Dr. Yao serves as a team physician for UCSB, Westmont College, and several high schools in Santa Barbara. In his spare time, he enjoys spending time outdoors with his wife and 3 children. Please join me in welcoming Dr. Yao.
Hi, good afternoon. Thank you, Christy, for the introduction. I thank you all for taking time out of your day to participate in this event. The purpose of my talk today is to provide some basic concepts as well as introducing some of the common diagnoses surrounding the shoulder, hip, and knee of an aging athlete. I have a lot of information to get through, and we'll try to accomplish that in the next 40 to 45 minutes. I do apologize in advance if some of the topics are brushed over quickly, but at the end of the talk, my hope is that you will walk away with some additional knowledge of how aging affects the shoulder, hip, and knee, as well as some ways to maintain and maximize your joint health. For this talk, I have no disclosures and no commercial support. And the objectives of this talk, as mentioned before, is to help you understand common disorders of the shoulder, hip, and knee in the aging athletes. We'll discuss diagnosis and treatment options, both non-surgical and surgical, as well as touch on some regenerative and biologic treatment options in musculoskeletal care at the end of my talk. So in discussion in terms of what happens in the aging athletes, we want to understand what happens to the joint and soft tissues with aging. Some common things do apply. Osteoarthritis is something that you probably have all heard about, and it refers to cartilage thinning and loss of cartilage. Tendinopathy and partial tears of tendons are also seen as a degenerative nature seen in an aging athlete. This is associated with collagen disorganization, leading to partial tears and full thickness tears. Inflammation is also associated with aging. One of the major changes that occur during aging is the dysregulation of the immune response, leading to chronic systemic inflammatory state, also showing signs of pain and swelling. There are other forms of inflammatory diseases that can actually cause joint swelling and pain. And some of that's related to autoimmune inflammatory disease. Some of that you may have heard of or have come across in either friends or families, and these are known as rheumatoid arthritis, systemic lupus, type 1 diabetes, psoriatic arthritis, multiple sclerosis, as well as among others. In discussion with osteoarthritis, we're referring to specific joint deterioration. And when we talk about joint deterioration, it's primarily talking about cartilage deterioration. The pictures here depict a hip joint as well as a knee joint showing signs of cartilage loss. So cartilage is the covering of the bone surfaces at the level of the joint. It provides cushioning to the joint as well as fluidity of movement. On the picture on the right, you see that there are significant cartilage damage, and that is what the essence of osteoarthritis is about. It oftentimes causes bone changes in the form of bone spurs, as well as bone hardening, known as subchondral sclerosis, and also oftentimes associated with cyst formations of the bone. Tendinopathy, also known as tendinosis, is a degenerative component that happens to collagen fibers. Collagen fibers are what makes up tendons that join your muscles to the bone, and this collagen can get disorganized over time as a result of aging. This can lead to pain, swelling, and inflammation, as well as tearing of the fibers of the tendon. Now we're going to delve into specifically different joints, specifically both the shoulder, and then later we'll talk about the hip, and then followed by the knee. To understand shoulder problems, we have to understand anatomy, and I'd like to go over some common disorders, as well as how to diagnose them and the various treatment options associated with that. When we look at anatomy of the shoulder, we're really looking at the bony anatomy, and that really includes the upper arm, also known as the humerus. So the humeral head and the junction of the glenoid, which is the socket of the shoulder joint. And the socket is connected to your shoulder blade. Multiple ligaments are utilized in these joints to give stability, and that includes the AC joints, the CC joint, as well as the actual glenohumeral joint, which is the true shoulder joint. Muscles then surround the bony anatomy, and a lot of you may have heard of rotator cuff muscles or tendons, and these are the ones that surround and provide motion to the shoulder. Other muscles, including deltoids, biceps, triceps, are also included in this as well. Common disorders of the aging shoulder. We oftentimes hear about the diagnosis of shoulder impingement, subacromial bursitis, tendonitis, especially of the biceps or rotator cuff. Acromioclavicular, also known as the AC joint, and we can see joint sprains of the AC joint, or even dislocation or separation. Rotator cuff tears is among common disorders of the aging shoulder. And finally, glenohumeral osteoarthritis, which is more broadly known as shoulder arthritis. When we look at shoulder impingement and subacromial bursitis, the phenomenon that happens when there is decreased joint space between the roof of the shoulder and the humeral head. The supraspinatus tendon is one of the rotator cuff tendon that oftentimes get irritated as a result of shoulder impingement. The bursa sac is actually a potential space that sits on top of the tendon structure within the shoulder. And on the picture on the right, you can see if there's narrowed space or reduced subacromial space, what will happen is that there's more friction in terms of the actual rotator cuff tendons, as well as the bursa lying above it. This can lead to pain, inflammation, as well as loss of motion of the shoulder. Tendonitis and tendinosis around the shoulder often refers to the biceps tendon and the rotator cuff tendons. And these can oftentimes lead to similar symptoms of pain, loss of motion, as well as weakness. A specific type of tendonitis seen in the shoulder relatively commonly is known as calcific tendonitis, in which on the picture on the right, you can see there are calcific nodules that deposit within the insertion site of the rotator cuff tendons. And this can also lead to irritation, pain, and loss of motion. Acromioclavicular joint sprain. This is referring specifically to the acromioclavicular joint, which is a small joint that joins the distal clavicle, which is your collarbone, to the acromion, which is part of the shoulder blade. This joint can oftentimes get injured through a fall or a laterally directed blow to the shoulder. It can cause damage to the ligament structures, and it can actually cause the joint to dislocate if the force is big enough. Another common diagnosis are rotator cuff tears, and there are various forms of rotator cuff tears, judging from small partial tears to large full thickness tears. And these are the primary mobilizers of the shoulder, as I previously discussed. And this is one of the common findings of shoulder pain in the aging athletes. Osteoarthritis in the form of glenohumeral osteoarthritis, which is the true shoulder arthritis, is depicted in these photos here. This is loss of joint space secondary to loss of cartilage. And then we see the progressive bone changes associated with cartilage loss in osteoarthritis, which are bone spurs, as you can see on the x-rays on the left, decreased joint space, as well as increased whitening of the bone on x-ray, which is known as subchondral sclerosis. Diagnostic tests of the shoulder. Physical examination finding, a thorough physical exam also always gives us a hint in terms of what is actually going on in the shoulder, and oftentimes can lead us to give us an idea of what is actually causing the pain and how do we deal with it. Next steps are usually imaging. Imaging modalities, including x-rays, ultrasound, and MRIs, are often used to hone in on the diagnosis. Aside from that, I oftentimes discuss with patients the use of diagnostic and therapeutic injections. And these are where we can actually target specific areas of the shoulder to test to see if that is a true pain generator or not. Oftentimes around the joint, we oftentimes see pain referrals. And sometimes where you hurt is not the origination of pain. And this is our opportunity to find out exactly where the pain is being generated from by injecting local numbing medication, possibly some corticosteroids to decrease inflammation to see if it changes your symptoms. And this can be targeted specifically to the glenohumeral joint, the acromioclavicular joint, subacromial space, biceps tendons, or other parts of the shoulder. Moving on to treatment options. Most of these diagnoses will start with conservative treatment options, which are non-surgical options. Anti-inflammatory medications in the form of non-steroidal anti-inflammatories, also known as NSAIDs, are the common medications that everybody hears about. Ibuprofen, Advil, Motrin, Aleve, aspirin. Those are all part of the anti-inflammatory cascade of medications that we can utilize to treat pain. You can utilize injections, as I mentioned a little before. Corticosteroid, also known as cortisone, is a powerful anti-inflammatory that one could take by mouth or be injected directly into the joint that is causing pain. Other injections include biologic and regenerative injections known as platelet-rich plasma, also known as PRP, as well as various stem cell treatments that are on the market today. We will delve into that a little bit later on during our talk. Pain modalities are oftentimes used by providers and treatment providers to help with patients' pain. These include, but not limited to, ultrasound, TENS units, which are electrical stimulation units, acupuncture, massage, cupping, myofascial release, ice, heat, and other forms of modality treatments for pain. We know that pain is oftentimes multimodal, so that oftentimes utilizing these various modalities, we can actually target patients' pain and make them better. Other treatment options that are non-surgical in nature include short-term activity modification. This includes decreasing overhead activities as well as heavy lifting in shoulder patients. And most importantly, physical therapy focusing on shoulder mobility and progressive strengthening exercises in a controlled fashion is oftentimes incorporated in the non-surgical treatment for joint pain. Oftentimes, we have seen many evidence-based studies showing the benefits of physical therapy rehabilitation exercises surrounding musculoskeletal care. Moving on to surgical treatment options in the patients that don't respond to conservative non-surgical options. For shoulder impingement and bursitis, we would consider shoulder arthroscopy, which is a minimally invasive surgery, also known as a clean-out surgery. It oftentimes includes debridement of diseased tissue, excision of the subacromial bursa, which is inflamed, as well as decompression of any bone spurs that are causing impingement for the patients. Surgical treatments focusing on AC joint sprains or injuries of the AC joint includes shoulder arthroscopy with debridement or cleaning out of the AC joint, as well as distal clavicle excision, where we shave off the distal 5 to 10 millimeters of bone to decrease the rubbing and engagement of the bones within the AC joint. Oftentimes that will relieve the patient's pain. Treatment options for rotator cuff tears. For those that have not benefited from conservative treatments or ones who have full thickness tears with the retractions, surgical repair is the best bet for rotator cuff tears. In these situations, oftentimes it is done through an arthroscopic approach in which we utilize anchors and sutures to tie the tendon back to bone. Once the tendon can reapproximate back to bone, then the healing process may begin. As far as glenohumeral osteoarthritis or chronic irreparable rotator cuff tears that are too large to repair, the main focus of surgical treatment in these patients are shoulder replacements. There are 3 forms of shoulder replacements. One is the anatomic total shoulder, a reverse total shoulder, and the hemiarthroplasty, which focuses on just replacing part of the joint, not the entire joint. And some of these examples and pictures are shown on the right. Moving on to the hip, We will again go through the anatomy of the hip, common disorders, the diagnosis and treatment options for these diagnoses. The hip anatomy starts with the bony anatomy of the pelvis. It involves the proximal femur, which is also known as the thigh bone. The femoral head is part of the ball and socket joint that makes up the hip. The socket side is attached to the pelvis, which is known as the acetabulum. And the various structures around the pelvis forms a ring surrounding the pelvis to give it stability. There are numerous muscles surrounding the pelvis and hip area. Some of them you may be familiar with. The large muscle groups includes the gluteus maximus, medius, and minimus, as well as what we call the adductor tendons, which are the groin muscles that give you stability as well as power in bringing the legs in. There are also external rotator muscles at the backside of the hip that you may have heard of, which we call the piriformis, and the obturator muscles. So moving on to common disorders of the aging hip, the often diagnosed trochanteric pain syndrome, which includes bursitis, as well as gluteus tendonitis, iliopsoas tendonitis, which is also known as hip flexor tendonitis, femoroacetabular impingement, also known as FAI or hip impingement, hip labral tear, as well as hip osteoarthritis. First, we'll talk about greater trochanteric pain syndrome. This includes multiple diagnoses: trochanteric bursitis, iliotibial band syndrome, gluteus medius minimus tendonitis and tears, as well as referral pains from the lumbar spine due to nerve pain are all included in this greater trochanteric pain syndrome diagnosis. And this is usually pain located in the lateral and posterior lateral hip area, and it can radiate down the lateral thigh. Iliopsoas tendonitis, also known as hip flexor tendonitis, oftentimes refers to a phenomenon in which there's irritated hip flexor tendons and muscle complex. This can lead to pain in the deep groin, as well as stiffness on stretching. One of the diagnostic tests is called the Thomas test that you see on the left. A positive test reveals that there is stiffness in the hip flexor motion, in which when you do the test, the hip on the affected side will lift off the bed. Next, we'll move on to femoral acetabular impingement, also known as FAI. FAI comes in multiple forms depending on where the impingement happens. We are referring to specific bony impingements in which excess bone can be formed in various aspects of the hip that causes an actual mechanical impingement. One is known as cam impingement, as you can see via the x-ray on the left, as well as the center picture where there's excess bone formation on the femoral neck. As the patient flexes the hip up, that bone can engage the socket, causing pain, as well as damage to the labrum, which is a soft tissue structure attached to the socket. On the picture on the far right, it's known as a pincer impingement, where the bone spur actually juts out from the acetabular rim on the socket side, which can create an impingement phenomenon when the hip is flexed into position. FAI can increase risk of labral tear as well as progressive hip pain, and it can increase the risk of early osteoarthritis. Hip labral tear. The labrum, as you can see in the cadaver image on the right, is a soft tissue structure that surrounds the socket. Its function is like a suction cup. It provides a negative pressure seal to the ball and socket joint of the hip. It can be seen in terms of labral tears with normal aging, and it does not always cause pain and dysfunction, and therefore accurate diagnosis is important, and the conservative treatment option important as well. Most people can actually improve without surgical treatment. In the patients that don't, I will get to what surgical options are there. Hip osteoarthritis refers to cartilage degradation, and this is often a progressive disease associated with aging of the joint. It is not dissimilar to what we saw earlier with the shoulder, in which you get bone spurs, subchondral sclerosis, which is bone hardening, as well as bone cyst with a loss of cartilage. Diagnostic tests for the hip include the physical exam, which includes a motion strength testing on the table to help clue us in terms of where the actual trouble is. Then moving on to imaging, which is similar to that of the shoulder, which includes x-rays, ultrasound, and MRIs. And diagnostic and therapeutic injections are also useful in the hip area to diagnose the actual cause of pain. Being that hip pain oftentimes coincides with low back pain and nerve referral pain, I do think that diagnostic and therapeutic injections oftentimes prove extremely useful to honing in on an accurate diagnosis. Non-surgical treatment options are very similar to that you'll see with the shoulder as well as knees. Anti-inflammatory medications, injections, as mentioned previously in the form of steroids or PRP and biologics are useful in hip treatment as well. The pain modalities are similar in nature and can also be utilized in diminishing pain. Specifically in the hip, activity modification exercises will decrease repetitive stress loading. And this includes minimizing running, heavy squats, and prolonged sitting for a short period of time while the pain subsides, then progressing into more physical therapy, rehabilitation, and strengthening to try to improve joint function and decrease pain over time. Again, just like with the shoulder, many evidence-based studies are showing that physical therapy rehabilitation exercises can be very helpful in the aging hip. Moving on to surgical treatments for patients who are not managed well with non-surgical options. For intractable pain secondary to trochanteric bursitis, iliotibial syndrome, or tendonitis, one could consider hip arthroscopy with debridement and bursal excision and iliotibial band lengthening. For gluteus medius and minimus tears, just like that of rotator cuff tears in the shoulder, we can repair these tendons either through an arthroscopic technique or through an open approach. Surgical treatment option for hip flexor tendonitis or iliopsoas tendonitis. You can perform an arthroscopic iliopsoas release to increase the mobility of the tendon. However, one must be cautious that this is not recommended unless all conservative treatment has been exhausted. As far as femoral acetabular impingement, arthroscopic surgery can be utilized to repair the labrum that has been torn as a result of hip impingement and to remove excess bone to prevent from further engagement and further damage. As you can see from the x-ray down below, the left-hand image shows a preoperative x-ray of a patient with a fairly good size CAM lesion, which is the bump on the femoral neck, and then postoperative surgery pictures, which shows that that bump has been resected and the normal contouring of the head and neck junction have been restored. For treatment of osteoarthritis, especially in moderate to severe case, total hip replacement would be the gold standard treatment. This replaces the proximal femur as well as the socket with a new bearing made of some form of metal alloy, oftentimes with a plastic bearing. Moving on to the knee, we will discuss knee anatomy as well as common disorder, its diagnosis, as well as various treatment options. When delving into knee anatomy, we notice that the bony anatomy of the knee includes the kneecap, also known as the patella, the distal femur, as well as the proximal tibia. There's numerous ligamentous structures surrounding the knee that gives it stability. Many of you may have heard of the anterior cruciate, also known as ACL, posterior cruciate ligament, known as the PCL, as well as the medial and lateral collateral ligaments, known as the MCL and LCL, respectively. You also have your quadriceps musculature and your multiple tendon structures around the knee that allows it to function. The tendons surrounding the knee, the most important ones, or the common ones that you may have heard of, are the quadriceps tendon, the patella tendon, as well as the medial and lateral retinaculum that gives stability to the kneecap. On the image on the right, we're looking within the knee itself. There are two C-shaped or horse-shaped disc structures known as the meniscus. You have a medial and lateral meniscus, which are essentially cushions within the knee. The common disorders of the aging knee includes patellofemoral pain syndrome, also known as kneecap pain. You can get tendonitis and bursitis around the structures of the knee. You can suffer from extensor mechanism injuries as a result of injuries, as well as meniscus tears and ligamentous injuries. Finally, osteoarthritis can also affect the knee. First, patellofemoral pain syndrome refers to both patella chondromalacia as well as patella instability. Chondromalacia specifically is a terminology to refer to cartilage damage. And we're specifically looking at the kneecap joint, which is the undersurface of the kneecap, and the trochlear groove, which is a groove that the kneecap tracks in. On the picture on the right, you can see wear of the cartilage structures. This is isolated to the kneecap joint, and this will likely cause pain in the anterior knee. In the X-ray image on the bottom left, this is an X-ray showing the left versus the right. We can see obvious deformity of the left knee. The kneecap seems to be tracking off center. This is known as patella maltracking or patella instability. When the kneecap tracks off center, it increases the peak forces to certain parts of the kneecap, leading to increased signs of wear, as well as increased inflammation and pain associated with that knee. Next is tendonitis and bursitis around the knee. Patellar tendonitis is a common phenomenon with pain of the patellar tendon, and this is the tendon just distal or just below the kneecap. We also see quadriceps tendonitis, which is basically at the insertion of the quadriceps tendon right above the kneecap. Pes bursitis is a phenomenon of pain located at the hamstring tendon insertion site on the medial knee. And this is an area where the bursa can become inflamed, and one can be quite tender just below the knee on the medial side. Extensor mechanism injuries refers to various injury patterns. First one is patella tendon tears. Second is quadricep tendon tears, and this is based on the location of the tendon tear, whether it's above or below the kneecap. Oftentimes with falls, we can also see patella fractures, as you can see in the X-ray as well as the picture on the bottom left. This is a crack through the patella, also known as the kneecap, and can create significant pain and weakness of the extensor mechanism. The extensor mechanism is what allows the knee to function, and it is a very important part of knee function. Meniscus tears are also a common phenomenon that is seen among the aging athletes, and this is differentiated into an acute tear versus degenerative tear. The difference is that acute tears often relates to a specific injury, oftentimes a twisting or pivoting injury, leading to increased stress and tearing of the meniscal tissue. Degenerative tears are seen as a phenomenon of aging. These are tears that are seen without a specific injury. Oftentimes, patients will have progressively worsening pain over extended period of time without actual injury. And when we get an MRI, it shows signs of a degenerative tear. Ligamentous injuries. This includes the anterior cruciate or posterior cruciate, also known as ACL and PCL, or the medial collateral or lateral collateral, which are the collectively known as the MCL or LCL ligaments. These are oftentimes a twisting injury or a direct blow injury to the knee. These are not typically injuries that are sustained without a definitive injury mechanism, meaning ligamentous injuries typically occur as a form of injury rather than just a progressive pain that progresses with time. Knee osteoarthritis is not any different from hip or shoulder osteoarthritis. And the picture on the right is a cadaver image of a normal knee with normal cartilage on the left-hand side of that right-hand picture. On the right-hand side, you see that there are degradative changes to the cartilage. It is not as smooth, it is not as white, and it is not as glistening as the one on the left. X-rays can clearly show signs of osteoarthritis. And on the picture on the left, you can see significant loss of joint space. You can see bone spur formation, as well as increased whitening of the bone surfaces, known as subchondral sclerosis. Non-surgical treatment options are very similar as previously described. Anti-inflammatory medications can be utilized in acute inflammation, secondary to one of the diagnoses of the knee. In the knee, we also have the option of giving what's called a hyaluronic acid injection, also known as HA injection or a lubrication injection. This is FDA approved for use for the knee, although off-label uses for hip and shoulder arthritis have also been used. Steroids and biologic injections can also be utilized within the knee for treatment of the various disease processes. Pain modalities, again, can be very helpful in mitigating pain for patients with knee problems as well. Activity modification, specifically with the knee, means decreasing repetitive stress loading activities. Again, running, squatting, lunging, as well as prolonged sitting in the short term oftentimes will relieve pain. Then, long-term wise, we would like to focus on physical therapy and rehabilitation exercises, specifically looking at the gluteus musculature up at the hip, as well as thigh strengthening, including the quadriceps and hamstring muscles, as well as flexibility and mobility of the knee to maintain good joint health. For patients who don't do well and continue to struggle with pain, there are various surgical options for the various diagnoses. For patellofemoral pain, surgical treatment options include knee arthroscopy with chondroplasty, which is basically cleaning up of the diseased cartilage. We use arthroscopic shavers to remove loose pieces of cartilage and to smooth out surfaces for better function. Lateral release and tissue balancing are helpful in patients with maltracking and malalignment. Oftentimes, people who have really bad malalignment or recurrent patellar or kneecap dislocations oftentimes will require an open realignment surgery in which we reshape the way that the kneecap tracks. Finally, for significant or severe osteoarthritis of the kneecap joint, patellofemoral joint replacement can be initiated. For tendonitis and bursitis, surgical treatment options include open debridement of the patella or quadriceps tendon, followed by repair. In this case, we would be excising the diseased tissue within the tendon structures that's causing pain and inflammation, and then repairing it once and for all so that the tendon can heal appropriately. If it's chronic pes bursitis, which is the hamstring bursitis, a surgical excision of the bursa can be performed to decrease pain and inflammation in this area. Extensor mechanism injuries can also be treated surgically. Open repair of quadriceps or patella tendon ruptures are a good way of restoring function to the knee once the tendon is torn. For patella fractures, open reduction, internal fixation with hardware, including either wires and cables or plates and screws, are utilized to hold the fracture pieces together as the bone heals. For meniscal tears, the surgical treatment option would be arthroscopy, which are minimally invasive surgery utilizing a camera. And the meniscal tissue would either be debrided based on the pattern of the tear or repaired, as the picture on the left shows, through sutures. Ligament injuries, depending on what type of ligament injuries, different surgical treatment options can be performed. Arthroscopic assisted ligament repair or reconstruction for ACL and PCLs are commonly done. Open repair and reconstruction of medial or lateral collateral ligaments can also be done in the appropriate cases. As for osteoarthritis, various treatment options do exist, and part of this relates to where the arthritis is within the knee. If there is only part of the knee that is arthritic, one could consider partial knee replacement, which is shown by the pictures here. If the arthritis involves two or more of the compartments of the knee, then a total knee replacement would be the appropriate surgery. Now, moving on to regenerative medicine and biologics. You may have heard a lot about regenerative medicine and biologics, as it has been really coming to the forefront of musculoskeletal care within the last 5 or 10 years. There's still a lot of research ongoing in regards to this topic, and there are various treatment options available to market now. Platelet-rich plasma, also known as PRP, bone marrow aspirate concentration, also known as BMAC, adipose-derived mesenchymal cells, which is mesenchymal stem cells derived from fat, amniotic fluid allograft, which are donated tissue from the amniotic sac after the baby has been delivered, that has been harvested for high concentration of growth factor tissue. as well as placental-derived stem cells, which are also donated tissue, although not widely available and currently research use based only. Generally speaking, the research shows that biologic injections can be very helpful in improving pain and function in various aging diagnoses of the musculoskeletal system. However, it remains very controversial if it truly regrows cartilage and tendons in the humans. It's often associated with very high costs, and insurance do not cover the payments of these treatments. However, there are no real major downsides, as most of these products are obtained from the patient themselves, except for the donated tissues, which we had mentioned before, which includes amniotic and placental-derived allograft, which is a term that refers to donated tissue. These can obviously introduce the low possibility of infection risk. As mentioned before, there are lots of research ongoing in the field of anti-aging as well as regenerative medicine, and this may all lead to improvement in treatment options for degenerative joint disease. So final takeaways from the talk in regards to aging athletes. In general, regular joint movement, strengthening, and exercises are highly recommended. We know that through research, it improves cartilage health, maintains flexibility and strength, and prevents injuries. Pain does not always equate to further injury or damage. Oftentimes, if there are no injuries that have occurred, it's often safe to initiate rest, ice elevation, and NSAIDs for 1 to 2 weeks to see if symptoms improve on their own. You can seek medical advice to establish the proper diagnosis and understand both the non-surgical and surgical treatment options, should that be needed. Experiments with biologics can provide significant pain relief and possibly benefit in degenerative cartilage and tendon structures of the aging athletes. And that will conclude my talk today, and I'm happy to answer any questions.
Thank you so much, Dr. Yao, for that very informative and interesting presentation. It's interesting, we got a lot of questions come in the beginning, but I think you answered many of them. But we will move on to additional questions that have come through. And just so you all know, again, because I'm seeing quite a few, so we'll get to as many as we can, and then we'll provide some contact information at the end in case your question isn't answered in the amount of time that we have left. So Dr. Yao, the first question we have is someone who really doesn't want surgery. Should they still go seek advice from an orthopedic surgeon?
That's a great question, Christy. I think that there may be some misconceptions that orthopedic surgeons are surgeons and you don't see us unless you need surgery. But that's largely not the case. As I can tell you in my practice, majority of the patients I see probably do not need surgery. And so the benefits of seeking help with an orthopedic surgeon largely is to just help understand what the diagnosis is, as well as what are the treatment options, and hopefully come up with a good treatment options with you as the patient, rather than just offering surgery as the only definitive option.
Great, thank you. That makes sense. Can Celebrex be taken as needed versus indefinitely for bursitis or tendonitis in both shoulders and hips?
Yes, so Celebrex is a great anti-inflammatory medication. It is also the one anti-inflammatory or NSAID on the market that actually helps coat the stomach. So for patients who have issues with gastritis or reflux, Celebrex is a powerful medication to be utilized for pain. However, as with any medications, there tends to be long-term potential side effects. It doesn't necessarily happen in everybody, but we do know that with these medications, and Celebrex included, it can increase risk of cardiovascular issues, kidney issues, and hypertension or high blood pressure. So the idea of taking Celebrex or any anti-inflammatories indefinitely is certainly something that warrants further discussion. In general, I would say I would recommend not thinking about taking it as an indefinite medication. However, you can discuss that further with your primary care doctor should that be a need. But the thought is that the longer you take it, the more consistently you take it, the higher risk for possible side effects.
Great, thank you. We had a question about any new surgical methods when replacing knees.
Yeah, so there are always methods and techniques that tend to improve with time. Specifically, I would imagine you may be referring to knee replacements. And if that's the case, there are various techniques that tend to get published with research. All in all, even between the minimally invasive, which still requires open surgery to do the knee replacements, a lot of it just focuses more on how do we preserve some of the muscles and tendons so that we don't have to cut through them. So yes, in essence, there are new techniques. Whether or not they are going to be largely beneficial in the long term hasn't necessarily borne out completely in literature, meaning that a good knee replacement that's put in correctly, whether you do it through a traditional approach or through one of the newer, minimally invasive techniques, all tend to seem to benefit well for the patients without dramatic differences in the long run. The hope is that some of the newer techniques is that in the early stages, maybe we can help with decreasing some pain associated with the surgery.
Okay, great. Thank you for that. Can a tear in the shoulder cuff be repaired without surgery? I think I heard you say that is the suggested course of treatment, but is it possible to have other courses of treatment for a shoulder tear?
Yeah, it really depends on what specific tears we're talking about. If we're talking about rotator cuff tears, we see a lot of partial rotator cuff tears that certainly can be treated without surgery. Now, when we get to a grade where we oftentimes differentiate between low grade versus high grade partial tears, which is essentially really means how much tendon is affected. The natural history study showing large kind of high grade partial tears, which is basically affecting more than 50% of the tendons, oftentimes will lead to full thickness tears. Once you have full thickness tears, a lot of times the dysfunction can be pretty significant. And in those cases, the only way to improve that is to repair that. However, because we know that rotator cuff tear is an aging phenomenon, and we know that as we age, sometime in the latter ages of our lives, a lot of times our demand becomes lower. And so the evidence does show that if you are lower demand, you can certainly live with rotator cuff tear, even full thickness rotator cuff tears without significant pain. If you don't have significant pain, then I don't think surgery is necessarily warranted. So I think this is it's a tough question because I think it's gonna be a case by case basis. Some patients, especially young active people with full thickness rotator cuff tears, just don't do well. And essentially you can attempt to try to treat it conservatively, but we know that the tendon is not going to reattach itself. And if you continue to have pain and weakness, then surgery would be the answer for that. So it's a long-winded answer, but I think for your specific case, I would say, we would want to look at what specific tears are we talking about, how big of a tear is it, and how debilitating or dysfunctional is it causing your life.
Thank you. We've had quite a few questions about stem cell therapy, and I know you covered, a whole section on regenerative, but can you speak specifically a little bit more about stem cell therapy?
Yeah, so stem cell therapy is one of those controversial therapies, even this day and age with all the research we have. The reason being is that it is still an unproven area, and there are so many different aspects of how do we obtain the stem cell? What stem cells are we using? How are we utilizing it? So there still are a lot of questions trying to be worked out. However, there are millions and millions of research money delving into this field of regenerative medicine. So I do think that there are some promise in the near future. And it's hard for us as providers to really kind of hone in on what is best? Should we all be doing it? What should we be doing? Without definitive evidence that it actually is doing good. It still remains very costly. Stem cells is a terminology that oftentimes we try to shy away from using because of federal regulations and various things on what is a stem cell, what refers to stem cells, and there are some regulations surrounding that prevents us to call certain cell types stem cells, even though in the marketing world online, everything is referred to as stem cells. So I think that I don't want to get into too much of the nitty-gritty of, does it work? I think there are definitely studies that show it can be very beneficial in certain circumstances. But as far as a broad spectrum, do stem cells regrow cartilage so that you don't need a knee replacement? We just haven't seen definitive evidence that stem cell therapy is going to regrow cartilage to a point where your MRI changes for the better. You don't need surgery. However, it can improve pain, it can improve function, it can decrease swelling. So there is some really kind of good that has come out of stem cell research up to this point. And I'm very optimistic that we're going to have a lot more options to utilize in the coming years.
Very interesting. Good to know. We've had quite a few questions about if someone can't take or just alternatives to NSAIDs, which non-steroidal anti-inflammatory drugs, for those of you who don't know, any alternative medications for that?
Yeah, so a lot of patients do have success with anti-inflammatory diets. I don't think that is as quick of a fix as an anti-inflammatory medication per se. But especially in patients who have autoimmune or are prone to inflammation, they do see significant benefits through diet, through food. So that is something that we know can be part of a treatment program as well. Other medications, Tylenol, although not an anti-inflammatory, can help with pain. So a lot of patients do utilize Tylenol as a pain modality or a pain medication in those settings.
How long does a knee replacement last?
That's a tough question as well. I mean, based on literature from 20 years ago, we do see, there's a pretty high survival rate of 15 to 20 years. And these are basically knees that were probably put in the 90s and in the early 2000s. So technologies have changed over time, and the prosthetics and the prosthesis have improved in terms of wear characteristics. So it's hard to put a direct number on it. Most of the surgeons that you talk to will kind of guesstimate, 15 to 25 years as a safe bet. Although, I've certainly seen patients who are beyond those from these back in the 90s that they're still working well for them. So I'd say, it's safe to bet 15 to 25 years is probably a good ballpark. Probably with better technology prosthesis that we're putting in these days, we'll see the literature show maybe further prolongation of how long it lasts.
Great. Is there a limit to the number of injections that someone can receive?
Yeah, and this is, I would assume the question is referring to cortisone injections or corticosteroid injection.
Correct, yeah.
So,
and this was for shoulder in particular, but I would say if you could answer for knee as well.
Yeah, so my feeling is that we do see more and more data and more literature showing that steroids do and can cause some harmful effects in joints, specifically causing some further deterioration of the cartilage and ligamentous and tendon structures. So my general consensus is it's a really, really good and powerful medications for inflammation and pain. So, I do utilize it in my practice. There are some surgeons and some doctors that don't use it at all, but I think the idea is that you should really use it sparingly. I don't think there's any data that says, oh, you can only have 1 injection or 2 injections a year. So it's hard to say, hey, you should really, keep your injections to this number. But I think that less is always going to be better. So my general idea is, we utilize it for the acute pain, the acute inflammation, and that's how I use it. Sometimes, I may see a patient in which we need to discuss the use of steroid injection to the shoulder for frozen shoulder or for arthritis. And oftentimes we may even sometimes give 1 or 2 injections in a short period of time within a few months. And then the idea is to not have any more for an extended period of time for a few years. So I think general rule of thumb, less is better. Keeping it to below 1 or 2 a year is generally recommended, or moving to one of the other injection options aside from steroids to try to stay away from, repetitively putting steroids in the joint.
Got it. And to that note, what's the difference between a biological injection and a steroid injection?
So biologics refers to the whole field of regeneration. So things like platelet-rich plasma, your blood, bone marrow aspirate, which is one type of stem cell injections where we take from your bone, amniotic fluid, which is the donated tissue, growth factors. So steroid is a medication, an anti-inflammatory medication that we're injecting. Biologics is where we're trying to kind of utilize the cells of the body and growth factors and various things to help with the healing process in hopes that there is some regeneration taking place.
In a question about if you're an older athlete without any problems, what type of preventative medical assessment or potentially physical therapy do you recommend?
Yeah, so I think that's a great question. I think in general, the best idea is some sort of a maintenance program. Even if you don't have problem, that is phenomenal. But I do think that regular flexibility training, strength training, overall body health for bone health in terms of resistance loading, all those things can be beneficial for your skeletal system, which are the bones, as well as maintaining the muscle and ligament structures to the best of its capability. So I think that, most of us believe strongly that movement is good, and that, sitting around and not doing anything generally doesn't do your body good in the long run.
Okay. When an older person falls, or I guess any person, and they have a broken hip, where is it broken and how is it treated? I know that you answered in the hip section, but I think specifically,
sure,
you could delve into that a little bit more.
Yeah, so there are various different patterns of fractures. So the broken hips can refer to a couple different areas of the hip. So you can either break at the femoral neck, which is the junction between the head and the actual femur, which is the thigh bone. You can break kind of more closer to the thigh bone, called proximal femur or intertrochanteric femur fracture. And you can break the actual socket. So all of these are kind of considered hip fractures. And the location of fracture to us as surgeons and providers, it really varies in terms of what treatments we can offer you. As far as the patient goes, those type of treatment also alters what the rehab looks like. So I can't lump hip fractures kind of all in one because there's variations of hip fractures. But in general, when you break your hip, especially if there's a displaced fracture, majority of the time it's going to be some sort of surgical intervention to fix that so we can get you back on your feet.
Anything on nano knee surgery that you can speak about?
I don't know. I am not the expert. I don't know enough about nano knee to really kind of delve into details. Certainly, I think that you do see and hear about that being promoted. It's a certain type of way in terms of a new novel way of replacing a knee joint. Because I don't have a lot of expertise in that, I don't want to kind of give any false information. So I'm not going to really go into too much details and discussions about that.
Appreciate that. Are there any dangers of coating the skin by the injury with MSM?
Coating the skin, if there's any danger. Not that I'm aware of. I don't have a lot of experience using MSM myself, but I don't think, at least to my knowledge, I am not aware of any danger to the skin by utilizing it.
Okay. And a few questions specifically about Voltaren for knee and shoulder pain and for arthritis.
Okay, so Voltaren is an NSAID. It's a non-steroidal anti-inflammatory. It can actually be given orally by mouth in pill form, or it can be more commonly given as a topical ointment or a lotion. And so you can definitely utilize Voltaren as a topical, and it could be knee, shoulder, back, hip. It basically is transdermal. It kind of soaks through the skin, and you get some anti-inflammatory effects as a result of that. The efficacy of it is variable. I certainly see patients who say that it does provide significant pain relief, and then others that say that they can't feel any different than if they put any other lotion on their body. So I think that there is variability of how it works. It's certainly safer as topical form in terms of side effects versus the oral form, which can lead to potential side effects to other organs in the body if taken consistently for long periods of time. But I think it's a safe medication to try as far as topical. If it does work, great. If it doesn't work, then obviously don't bother.
Okay. And then is there one pain medication that you would say is kind of less harmful if you're going to have to take it over a long period of time?
Yeah, so my general consensus when I tell patients with that is that every medication has side effects. So in that light, oftentimes I do tell patients that if you can, I would consider interchangeably utilizing something like Tylenol or ibuprofen, but then using it separately so that you're not consistently taking the same medication over and over and over time. So that way you lessen the risk of potential side effects from a certain drug because you take it less often, and you get benefits of the different types of the mechanisms of action between something like ibuprofen, Advil, as well as Tylenol. And those are generally over the counter. They can be relatively safe if taken, in a sparingly, basically. And so if you can further kind of spread that out by interchangeably using the different medications, then I feel that is safest.
Okay, great. And we have about 1 minute left here, so I think I'll take one last question. This is with regards to blood thinners and the risk. This was specific to knee replacement, but really any type of replacement, joint replacement.
Blood thinner as far as, sorry, I missed the actual question. So
someone who is on blood thinners, are they more at risk for complications in a joint replacement?
Sure. Theoretically, around and surrounding the time of joint replacement, there are ways that we can minimize those risks. And some of that is certainly going to be discussed with the surgeon, as well as most people are on blood thinner because of something related to the heart. So it'll be a discussion between the cardiologist and the orthopedic surgeon in terms of how do we minimize those risks. Now, remembering most joint replacement patients will go on blood thinners after surgery to help decrease the risk of blood clots. So just because you start on you are starting with blood thinner even before surgery doesn't necessarily mean that you're going to be on significantly elevated risk. There are some increased risk for wound healing issues due to bleeding based on what anticoagulant you're taking, but in general, it will not preclude one from getting a knee replacement. And even though it does increase slightly the complication risk, it is not significantly increased to a point where you shouldn't consider or be scared to consider a knee replacement.
Thank you so much. So we are at the end of our program, and I know we had a lot of great questions here. If your question for some reason didn't get answered due to time, we're going to put up some contact information here. Dr. Yao is located at the Ryu Hurwitz Orthopedic Clinic, located here. Again, this presentation is being recorded, so you'll receive an email within the next week with a link to view the presentation and PowerPoint slides. A brief survey will be shown at the very end of this presentation, so we'd love to hear your thoughts. Thank you so much, Dr. Yao, for your time and your expertise. This was so informative and very interesting. With that, I will say thank you all for joining, and have a happy and healthy rest of your day.